That sounds like summer to me.
I know. Doesn't that sound so nice? Like, I just can't wait to get up to a cottage or do some camping or something.
Yeah, or sit by a pool with a cold drink in your hand with like the perspiration from the drink kind of going down, ice cubes crackling.
What an image.
Summer barbecues.
Yeah, summer barbecues. You know, it also reminds me that to go to all those places, I'm going to need to pack a lot of allergy pills.
Because these sounds are not only the sounds of summer, they're the sounds of summer allergies.
Oh, yeah. Are you allergic to anything?
I am not allergic to a single thing.
Oh my gosh. Why are you even on this episode?
What about you?
Yes, I am. I mean, if we're talking seasonal allergies, I can attest to losing so many summer days because of my allergies to something in the air. That's the worst part of this is I don't even know what I'm allergic to. I
have noticed, you coming in and you're always bright-eyed and bushy-tailed, but stuffed up.
Yes, almost always stuffed up. And I think that's part of the problem for a lot of people with seasonal allergies is we're not even sure what it is we're allergic to.
Oh, it's so weird. That must be terrible.
Yeah. And so many of us go through this. It's estimated that more than a quarter of Canadians suffer from seasonal allergies. And our guest today thinks that that number is probably even higher.
Hi, I'm Chris Shulgin. I'm Eat Move Think's executive producer.
Hi, I'm Jasmine Ratch. I'm managing producer. Welcome to episode 121 of Eat, Move, Think. Our guest today, Dr. Ann Ellis, is an MD, a professor of medicine, and chair of the Division of Allergy and Immunology at Queen's University.
She's been directing the internationally recognized Environmental Exposure Unit since 2008, where her research team evaluates and studies allergy medications in their cutting-edge allergen challenge chamber. What the heck is that?
Yeah, doesn't that sound crazy? I mean, they simulate an environment where you'd be allergic outside within this room.
Oh my God, that sounds like, I think, torture, maybe?
Torture, but all for the better. All for the better.
See, I could sit in there and just nothing would happen.
Oh my God. Anyways, today Dr. Ellis is in a conversation with Medcan's Chief Medical Officer, Dr. Peter Nord, about why we get allergies, what we can do about it, and whether or not you can get rid of yours for good.
Here's Dr. Peter Nord.
Welcome to Eat, Move, Think, Dr. Ellis. It's great to have you here on the show. How's your day going so far?
It's been busy, but it's been good.
Yeah, we have a little bit of summertime starting right now, a little bit of warm weather, so hopefully we can get out and enjoy that as much as possible.
Exactly.
Well, like many of our listeners, I actually have had seasonal allergies since being a kid. I can remember in grade 4 looking outside the classroom window and watching the grass being cut and my heart sinking just a little bit because I knew after that I was going to have a bad night. It was my nose is going to start to run, my eyes are going to get itchy, and as a result, I was always been interested in allergies, and so this topic is super timely. Back then, too, the only medication we had was like Benadryl, so things that would just knock me out. So even if I made it through the night, not being too groggy, the medication would knock me out as well. And many of us, like me, get these itchy eyes and runny noses, and there's stuff in the air that we're reacting to. What's really happening in the body? Maybe we can tell our listeners, why are we allergic to things?
So that's a great question. And basically, the important thing to realize is that not everybody has allergies, as you probably know, because this part of our immune system initially evolved to try to fight off parasites. So the part of the immune system that's responsible for allergies deals with what we call type 2 inflammation, which again has lots of different processes like antibodies we now associate with allergy, cell types that we now associate with allergy, but they were all evolved to help us expel worms from our body. And with industrialized societies, we don't have a lot of helminthic parasites anymore, and it becomes a little bit of that idle hands is the devil's workshop.
So hang on a sec, Dr. Ellis. So you said worms, like we're at seasonal allergies now, but it all started with trying to get rid of worms?
Yeah, so parasitic worms specifically, so the ones that like to live in your gut and intestines. So all of the types of chemicals or molecules that the cells involved with that type 2 inflammatory pathway, they all help to do things like increase mucus production. So you secrete a whole lot more things that can help, for lack of a cleaner way of saying this, making your gut slimy to make it easier to push the worms out. They cause vascular constriction. So again, smooth muscle contractility makes it easier to expel literally the parasites from your lower intestine. Again, things we haven't had to think about in many, many, many years in Canada. But that's kind of like all of the chemicals that those types of cells release tell our body to do things that help us get rid of parasitic infections. But now instead are telling us to make mucus in our noses and make us have stuffy noses and make us have unusual reactions to things that you shouldn't even be allergic to in the first place. But our immune system has decided this is now our foreign invader we're going to attack.
And flush it out. So just like,
we
have pollen in our eyes, we're going to water our eyes to keep the pollen out of our eyes, and our nose is going to run. So we, going to flush that, whatever it is, out of our nose. And I guess at one point we had to flush stuff out of our bowel as well. Wow.
Yeah, that's a great analogy. And so the Th2 side, or the type 2 side of our immune system, has unfortunately been reprogrammed to fight off foreign invaders that are actually innocuous proteins like ragweed pollen, like birch and grass pollen, and quite frankly, also things like peanut allergens. So it's one of these things that is what we call a hypersensitive response, which is fortunately not the entire population in Canada suffers from allergies, but certainly for those people who are prone to allergies or are so-called atopic individuals do suffer from these manifestations of allergic diseases, the most common of which is allergic rhinitis or hay fever / seasonal allergies.
Yeah, and you mentioned a couple of technical terms there, which we could probably unpack a little bit. One of the main things that most of our people go to when they think of allergies is antihistamines, and that's sort of fighting histamine. So maybe you could just do a short 30 seconds on what histamine is.
Yeah, so the main cell involved with acute allergic reactions, so things like allergic rhinitis or hives, for example, is the mast cell, and I call it my allergy cell, that when it interacts with proteins that you've become sensitized to, leads to that cell to fall apart and release a whole bunch of mediators, the most common of which, but not the only one, is histamine. And so that's why one of our first go-to treatments for allergic reactions is something that's an antihistamine. So histamine is a very key player in allergic reactions. It's not the only one, but it's definitely the first one we try to combat when we start to get into these types of issues.
Yeah, that's super helpful. Going through med school, immunology for me was one of the most complex parts of the curriculum. So my hat's off to anybody that can really get a handle on the complexity of the immune system. And, I think a lot of us are more aware just because of COVID and pandemic as well. But boy, it is complex. And so we're, trying to do our best to simplify as much as we can is really helpful for everybody. So I've had allergies my whole life. How likely is it that I'll grow out of the allergies? That's a question I get a lot from my patients, or even develop new ones as I go through life.
So that's a great question, and it really comes down to what is it you're allergic to in the first place. Again, we're focusing today on seasonal allergies or hay fever. Typically speaking, those types of allergies, if they start in childhood, you're going to likely be stuck with them. Some people do eventually, quote unquote, burn out, or they may get better if you move to a different geographic area where you're not exposed to the same allergen. In terms of risks of developing new allergies as you get older, we do still see that as well, particularly in the ages 20 to 40 category, much less likely once you hit sort of the 50, 60-year-old range. There is no always and there is no never in medicine, and it's even more true when it comes to the immune system. But generally speaking, allergies can evolve any time between childhood and sort of your late adult years.
And then when we think about seasonal allergies and hay fever, what is it that we're exactly allergic to? Like, because we hear about things like, to me, the hay fever sounds like a misnomer, and ragweed, like what is that?
Yeah, it's a great challenge for me to try to explain to everybody. I mean, hay fever evolved as a phrase to describe the symptoms that people would have when they mowed the hay in the falls. And that's ragweed, particularly, that people are reacting to at that time. But it's become a very colloquial phrase. It makes more sense to people than saying, do you have allergic rhinitis? Which is really what we're dealing with this time of year, which is due to tree pollen predominantly. And just around the corner, we just got whacked with it this weekend, grass pollen. are the main seasonal allergens that are getting us now. There's also lots of seasonal molds out there. You get a little bit of a break through the hiatus of the summer months, but then by August 15th, you can almost set your clock to it. Ragweed pollen will start to release. And again, we get a peak of ragweed pollen season in early to mid-September.
It seems like more and more people are actually suffering from allergic rhinitis these days. Is the allergy season getting worse?
So what's happening is the allergy season is becoming more unpredictable. Our winters are, for the longest time, we're getting longer. We were taking a longer time for the tree pollen season to get started in the spring, which meant that by the time the tree pollen finally started getting up and running, it wasn't too long before grass pollen kicked in. But there's definitely some data, particularly where I am in Kingston, to show that pollen levels are definitely higher now than they were, say, 10 years ago. Between the combination of the timing being different compared to previous, more overlap between tree season and grass season than we had previously seen, that can sort of culminate in the perception that allergy symptoms are worse than they were before. I would love to get a better sense. Again, it's been harder to study something like seasonal allergic rhinitis during COVID when everybody's been focused on studying COVID. But I do wonder if our prevalence of the condition hasn't gone up as well. Our best data to date suggests that it's about 25% of the Canadian population who suffers from allergic rhinitis. My gut feeling is that it's higher than that, though.
Yeah, it certainly seems like that. And again, for our listeners, allergic rhinitis is basically just runny nose, a medical term for runny nose allergic rhinitis. And so what are some of the things that I could do in my immediate surroundings to help reduce my allergy symptoms? I mean, do I have to avoid going camping or avoiding the cottage and obviously not going out and cutting hay? Like, what kind of things do I need not to do to keep myself safe?
So management of pollen allergies is challenging because you do need to go outside at some point, right? But simple things like keeping your windows closed, use air conditioning if you have it, having air filtration systems in place are all useful. Don't hang your clothes to dry on the line, even though that's more environmentally friendly. Your clothes are going to get covered in pollen and then you'll just breathe it all in when you go put those clothes back on. When you're in your car, have the windows up, air conditioning on to help filter that air. But unfortunately, when it comes to seasonal pollens, avoidance becomes imperfect at some point, which is why people end up seeing people like me.
Yeah, and so to that end, as I said, when I was younger, we didn't have much in the way of treating, and the medications that we used, the way we treated people, had some real side effects to it. It really, you imagine the challenge of a bunch of kids being a bit dopey on Benadryl as they're going through their classes that the next day after the grass was cut. So there's been a lot of, obviously, improvements in terms of allergy medications. Maybe you could just walk us through what some of the more common medications are, and maybe historically, again, some people might be still using Benadryl and other things like that. Maybe you could just kind of walk us through chronologically, where are we now in terms of treatment that we were not 20 years ago?
Yeah, absolutely. And thank you for spontaneously sharing your adverse events from Benadryl and those older first-generation sedating antihistamines. The Canadian Society of Allergy and Clinical Immunology has actually come out very strongly that people should not be using those older agents anymore for anything, really, but especially for seasonal allergies, because we have so many newer, safer antihistamines that are so-called second generation, or we just call them non-sedating antihistamines. And really anything that you see on the pharmacy shelf that says non-drowsy has met that standard for being a non-sedating antihistamine. These medications don't have that same side effect of drowsiness and the hangover effect you already described from your own personal experience of having taken these sedating antihistamines at night. And they're actually more effective to boot, and they kick in faster. So we really recommend, again, over the counter, we've got so many options. Alphabetically, there's Arius, Allegra, Claritin, Reactin. Again, there's generic versions of almost all of those as well. And we now have new prescription options that if you speak to your family physician, if you have private drug coverage, you can get 2 other non-sedating antihistamines that can be prescribed by your primary care provider to save you the out-of-pocket expense of buying it over the counter. So tons and tons and tons of safe and effective antihistamines that you can choose from instead of so-called Benadryl.
Perfect. And I guess we can also divide them by more systemic medications, so pills that you would take versus other strategies that would be more specific, like to deal with itchy eyes or specifically like the runny nose? What do you recommend in terms of those other more specific items?
Yeah, particularly if you have a lot of nasal congestion, not just the runny nose, but stuffiness, the nasal steroids are a good option. There's 2 that are available that you can just purchase over the counter, a myriad more that can be prescribed by your primary care physician, but also lots and lots of antihistamine-based eye drops that really go straight to the ocular symptoms because you're applying them right to the surface of the eye, and they can work better than the oral versions of those medications.
Great. And some of the questions I get from my patients too is that, I tried the over-the-counter Claritin and I got a little bit of benefit, but, I'm still having symptoms. Can I double up? Typically, these are all once-a-day medications. Can I take 1 pill twice a day? Is that good? Is that dangerous? Will it work?
So it's certainly safe to do so. Particularly, I treat a lot of patients who have chronic daily hives, and we know that we can safely give them even up to 4 tablets a day as long as you don't start to get into sedative side effects. I mean, there's no doubt the higher the dose is, the increased the risk would be of actually starting to feel a little bit of drowsiness. It'll never quite catch up to Benadryl, likely. Safe to do so, but it's also an indication that maybe you need to go on to something better than just the antihistamine in the first place anyway.
Yeah, that's great because that's something we often hear, can we do that? And the other question I often get is, I took the Claritin, fill in the blank, and one of the other over-the-counters, but it really takes a couple of days for me to get to steady state. Do we recommend that we take a couple of days to get this up to a steady state, or should we expect that after 24 hours we're up there and it's working fully after that just single dose?
So there's no doubt for some patients you'll need daily dosing to get maximum benefit. But again, if you really don't see any immediate improvement, it means you probably need to go to other first-line agents like the nasal steroids to add on to the benefits because they do treat different pathways, and you may get the added benefit from treating the nose directly with the nasal steroid as well as the oral antihistamine.
Great. And so as we mentioned, this histamine, we're talking about the antihistamines, and we mentioned histamine early on. So in terms of the over-the-counter medications, how does that actually work? How do the antihistamines actually block histamine without we don't have to get into the histology and the, too complex, but I know a lot of patients are asking, like, how does it actually work?
Yeah, and so obviously an antihistamine by default blocks the receptor that histamine binds to, which then causes its downstream effects. So there's no doubt if you wait until you're at the worst you've ever been in terms of your symptoms, by the time you take it, there might be a little bit of the barn door, you're shutting the barn door after the horse is out. So there is some thought around starting to treat earlier at the first onset of even mild symptoms so that you're not sort of chasing your tail. It doesn't mop up histamine once it's been released. It only blocks it from binding to its receptor. So I do sometimes suggest that patients start taking their antihistamines earlier on in the season to try to be covered and have those receptors blocked before your mast cells actually release the histamine in the first place.
That's great advice. That's really good. I'm sure a lot of our listeners really appreciate that. And more about me. The other part of my early relationship with seasonal allergies was around allergy shots. So I can remember being, just a kid. And every month I was in the doctor's office. I was getting my shot. And that was the kind of the de facto treatment. Benadryl and shots was back then was the treatment. So, a lot of our listeners that may have been through that are asking, so what was that useful? Do we use shots still today? Has it kind of fallen out of favor? We don't hear as much about shots. Did I need to have those skin tests to see what I was really allergic to? So in terms of the kind of initial workup, and then do we get into immunotherapy shots as much today as we did a number of years ago?
Yeah, absolutely. And thank you for bringing it up. And you're absolutely right. I don't yet know why people have not heard about so-called allergy shots or immunotherapy. They've been around for over 100 years. We've certainly refined the technology. A lot more of our allergens are standardized, so we have a much better sense of exactly what to put into those formulations for those injections to give you the best bang for your buck, that they'll actually change your immune system. And typically now, a 5-year course is enough to produce a long-lasting benefit to your immune system, and you can stop it after that point. More importantly, however, because the biggest problem with immunotherapy injections, as you may recall, is yes, you have to go to the doctor's office. You have to sit there for half an hour to be observed because there's a low but measurable risk of a systemic allergic reaction or so-called anaphylaxis. So they weren't without side effects. And now we have even more advanced, safer therapies where patients can treat themselves at home with the sublingual immunotherapy, which is a tablet that dissolves under the tongue. The first dose does have to be given in the doctor's office, and you're observed for half an hour after that first one. But if there's no problems with the first dose, you then just go home and take that same tablet in the convenience of your own home once a day. For seasonal allergens, it's for about 4 months before the season starts and all the way through the season. And then for things like house dust mite, you do have to take it all year round because obviously that's a perennial allergen or a year-round allergen. But yes, we still do what we call subcutaneous immunotherapy or the traditional allergy shots, but they've been more refined and are better understood now than maybe when you had them. And we also have the tablets, which is a huge step forward.
And are there any other exciting new treatments that are coming into play right now or in the future?
So yeah, there's lots of exciting things in the pipeline. We happen to be a site for doing allergy research, particularly with allergic rhinitis. I can't comment about anything that is not yet in the public domain, but fear not that there are a lot of companies that are working for even newer and better specific treatments for various allergies.
Well, that's great. Just to switch gears just a little bit, it does fall under the allergy banner, but a little bit different from seasonal allergies. Bringing it up because many of our listeners have asked in the past, and I know patients are asking. Parents have been told in the past to avoid feeding their kids certain kinds of foods. Don't give your baby X. And that was to either avoid allergic reactions or maybe even prevent allergies from developing. What's the recent thinking on this?
So the most recent recommendations, and they're not all that recent anymore, we've adopted them for quite some time, but there is no reason to delay the introduction of highly allergenic foods, regardless of family history or personal history of allergy in that infant. As you've alluded to, the American Academy of Pediatrics released this document back in 2008, suggesting that delaying the introduction of peanut or other highly allergenic foods might help to prevent the allergy. It's important to realize they didn't ask a single allergist their opinion on that document. It was a bunch of pediatricians. And not to say there's anything wrong with pediatricians, but it would have been helpful if they'd asked an allergist because we would have said something very different. And so many, many years later and a massive clinical trial to prove our hypothesis later. In fact, the LEAP study, which was published on the New England Journal several years ago now, did show that early introduction of peanut as early as 4 to 6 months while the infant is still breastfeeding, if they happen to be choosing that route, did lead to an 88% reduction in the likelihood of developing peanut allergy. And that was regardless of the risk of peanut allergy in that child. So it is a huge step forward to realize that you do need to introduce these foods early. It is for the most part safe. 88% reduction is obviously not a 100% reduction. But again, far less peanut allergy being seen de novo now since that study was released and guidelines were updated compared to when I was starting my practice and we were seeing a gamut of new onset peanut allergy because they were following those older recommendations.
Wow. So that's really why we're seeing today all the peanut allergies and schools have to be peanut free and that sort of thing. It all ties back to that.
Well, there's lots of reasons why there was that huge increase in food allergy generally. You don't want to blame it all on one recommendation, but that certainly didn't stop it. Let's put it that way.
Yeah, I guess we can say that for sure. Also, just in terms of popular issues that may be attached to allergies, there's rumors around certain things that could help allergies. So we've talked about the different treatments and proven and things that are in studies, but on social media, there's lots of information out there which is questionable about if I'm eating honey or raw honeycomb to treat allergies. If I drink green tea every morning, that's going to help. Any thoughts on any of those other maybe more natural remedies that have been put out there?
Yeah, so local honey is certainly delicious. Never been shown in any kind of study to actually treat symptoms of allergy. It probably just makes you feel good because honey tastes good. Same with green tea, again, not proven in any rigorous studies. Totally appreciate, though, there are people who want to pursue more natural therapies. So things like saline rinses are safe. It's just salt water. I do recommend people purchase the ones from the pharmacy just so you know it's sterile and properly prepared. And safe to use up to 6 times a day if you can find the time. So, and definitely beneficial.
That's great. That's what a lot of our folks are looking for, not just the sort of the pharmaceutical approach, but some things that might be more natural and easy to sustain as well. What would be your top 3 or 4 tips for the listeners when it comes to seasonal allergies?
So I would say first and foremost, move beyond the sedating antihistamines. I know it's tempting to go with the least expensive item on the shelf, but really those non-drowsy antihistamines will give you better relief. Your pharmacist can help you figure out which ones are the best ones. Second of all, don't be afraid to talk to your primary care provider about your struggles with allergies. They have options for prescriptions that, the pharmacist can't necessarily direct you to. And thirdly, and probably most importantly, your primary care provider can send you to a specialist. They can send you to an allergist that can really help you figure out exactly what you're allergic to. And you can have access to things like specific immunotherapies. So, don't be afraid to ask to find an allergist and find relief.
Thanks. That's great. A super summary to a very complicated issue. Well, we've covered a lot of ground, again, from somebody who's personally had a challenge in this area since I was a kid. This has been really interesting. And I know at this particular time in our seasons that we're going through in this area, boy, I'm seeing a lot of people with red eyes and runny noses and wheezing and coughing. And of course, during a pandemic, you're not looked upon very favorably with those symptoms because, of course, everything is pandemic and COVID until proven otherwise. So it's just one more thing that we have to worry about in addition to just dealing with our seasonal allergies. Dealing with it in a pandemic just makes it that much more of an issue. So thank you so much for your insights, Dr. Ellis. Hopefully this means more outdoor time and fewer trips to the pharmacy from our listeners. Take care and stay well.
Thank you. You as well.
That was Medcan's Chief Medical Officer, Dr. Peter Nord, in conversation with Dr. Ann Ellis, Professor of Medicine and Chair of the Division of Allergy and Immunology at Queen's University.
We'll post episode highlights and links you can visit on our website, eatmovethingpodcast.com.
Say hello and send us a tip or a suggestion by emailing us at info@eatmovethingpodcast.com. And follow Medcan on Twitter and Instagram at MedcanLiveWell.
Follow Dr. Ann Ellis on Twitter at Dr. Ann Ellis. That's DrAnneEellis.
Eat Move Think is produced by Ghost Bureau. Senior producer is Russell Gregg. Jasmine Ratch is managing producer.
Social media and strategy support is from Chantel Gertin and Andrew Imex. Executive producer is Christopher Shulgin.
We'll be back soon with a new episode examining the latest in health and wellness.
This podcast is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with the specific information highlighted. Any third-party links are not endorsed by Medcan.